So let's talk about scabies for a minute, or let's talk about parasitic infections. So regarding parasitic infections, we're going to look at two parasitic infections. There's obviously many parasitic infections that affect the skin, especially those caused by bed bugs. But we're going to focus on the two of the most important ones for today, and that is scabies as well as lice, or a scientific name for it, or let's say a medical term for it is pedunculosis infection, the causative agent of lice, especially in the facial hair. So let's talk about scabies. So regarding scabies, scabies is a parasitic infection of the skin, and it is caused due to a mite, which is where the term scabies come from, a mite known as a scabie. And this mite is a parasite that basically comes in contact with the skin due to contact. So if you have a child that is playing around, he's touching personal objects, these personal objects, especially around the house or from somebody from outside, could contain a mite. And this parasite, you see what it does is that it's very, very efficient. Is that this parasite right here, this mite will come in the skin. It will come in contact with the skin. And it's going to come specifically in contact with the stratum corneum layer of the skin, the outermost layer of the skin with a lot of dead cells. And once it comes in contact with the skin, this mite right here is going to start producing what? It's going to start producing eggs, or what they call it, basically little eggs, little children. So here we have a mite. It's right here in the skin due to contact, and that's how it's transmitted, through contact with anything. So that's why typically hygiene is very important, especially in children. But typically this mite comes in contact in the outermost layer of the skin. It starts to produce eggs of its own, tiny little children, and these eggs and the mite start to deposit itself in the stratum corneum layer of the skin. And because it starts to deposit itself in the outermost layer of the skin, this will attract the attention of your immune cells. This will trigger an immune reaction, all right? And of course, the immune cells, they will cause a reaction to this, along with the production of these eggs from the mite. Together, they will create a pathognomonic or a pathological change in the skin. And when there's a pathological change in the structure of the skin, this will lead to the appearance of skin lesions. Now, one thing to keep in mind as well is that when we look under microscope, what's going on here as well, there will also be the presence of feces, because again, these parasites, they tend to eat a lot of dead cells, they tend to eat a lot of the things surrounding them in the stratum corneum, so they will also bring out feces along with them. But let's go back to the point. So this is what exactly is happening in scabies. You have a parasitic infection of the skin due to a scabies mite that enters inside the skin due to contact, and the scabies, what's inside the outermost layer of the skin, it starts to produce its eggs, and this will trigger an immune reaction, and the immune reaction will lead to appearance of skin lesions. So what are the clinical presentation of a patient with scabies, especially with children? Well, the patient will come to you with a known case of itching at night. And that is what this parasite is. This parasite is very active during the night. So that's why a patient may come to you with very, very, very severe itching. Okay? A very severe itching, especially at night. Let's call it nocturnal itching. And that is a very characteristic feature of scabies. You can distinguish it from something like eczema or something from urticaria, where there's itching involved. Here, itching during the night only, or more prominently during the night, this might give you the diagnosis of scabies in your differential diagnosis, okay? So why is there itching specifically? Well, let's say we know why the itching occurs, which I mentioned before, but where does the itching mostly occur at night? What are the sites? Well, regarding to scabies, the sites can be anywhere, صراحة. يعني it could be on the abdomen, across the abdomen, it could be in the trunk, it could be in the armpit, it could be in the groin. But I'll pick the hand most commonly. I'll pick the hand of the patient, or specifically you might see skin lesions. You can see skin lesions in between the fingers. So they call it finger webs. You might see it in between the fingers here and on the flexor surface of the wrist, where you can see a skin lesion. And really, if you want to focus specifically on the skin lesion on the wrist, this is also the site of lesion where you can see cases of lichen planus or contact dermatitis. So scabies can join with the other two skin conditions in which you can see a lesion on the flexor surface of the wrist. But additionally with scabies, you can see it in between the fingers, and thereby the color red. So let's do a zoom in and see what does this skin lesion look like. Well, it appears as an erythematous papule, all right, or a vesicle, or anything, but typically a raised lesion that's erythematous in nature. And if you look at very closely, this very itchy lesion, this itchy erythematous papule or vesicle that might be present between the fingers or the wrist, if you look at it closely, you might see the appearance of a tunnel in the epidermis. And this tunnel, by the L-shaped letter in brown color, this is known as a burrow. This burrow is another physiognomic feature of scabies. This burrow basically comes as a result of mites deposited its eggs in a tray-like manner along with immune reaction, causes the appearance of a burrow. So a burrow, you can think of it as a tunnel across the epidermis, and it actually gives the color not brown, it actually gives the color of a gray line, like a gray line like this, like an L shaped or similar to it. So you can see it upon closer inspection, the presence of a burrow in the center of any lesion in the skin in the case of scabies. Alright? And that's going to be important for the burrow, not just for clinical diagnosis, but also in the case of if I'm going to do skin scraping to diagnose my case even further, I will scrap the part of the skin from the burrow where the parasite is most active. Okay? So that's what the skin lesion looks like in scabies. It could be anywhere in the body, we said before. It could be especially in the wrist. It could be in between the fingers, the finger webs, and it can appear as the presence of erythematous vesicles or papules with a burrow. And let's not remember, these lesions are very itchy, especially at night, nocturnal. Okay? So we finished with the lesion in mind. So how do I diagnose this case? You diagnose it as a case of clinical diagnosis, especially if you see a lesion in between the fingers. You can get an idea this might be most likely scabies. But to confirm it even further, you can also do diagnosis. You can do skin scraping. You can also not just rely on clinical diagnosis. You can also do skin scraping. So as we said before, skin scraping can be taken from the burrow where it's the most active. And then from my tools, I take my skin scraping. Once I scrap part of the skin, before I put it under light microscope, I will apply mineral oil. All right, before I can do visualization of the parasite. So I will take the skin scraping from the burrow, apply mineral oil, then I will put it on light microscope. And what will I see on light microscope? Three things. Number one, you will see the mite. Number two, you will see the eggs. And number three, you will see the feces that we mentioned before. So if you see a mite, an egg, and feces in that order, from left to right, or from anywhere in the microscopic slide, if you see that, then this will confirm for you the diagnosis of scabies under light microscope. Okay? So that's one way of diagnosing scabies, a sure way. Okay? Now, what about the prognosis for scabies? We said it's very itchy during the night. Is scabies bad? It depends. You see, scabies is a very contagious disease. It is very easy to be transmitted from one person to another, especially among families. So the thing about scabies is it can be very irritating to have it. And the thing about scabies is that the infection itself is not as bad. It's not really bad. It's not really something super bad, the primary infection. But the thing that comes bad with scabies is outside factors. For example, if a patient has HIV or AIDS or did an organ transplantation or has any sort of condition in which his immune system is down. So if a patient who's immunocompromised has scabies, then no, the prognosis is bad because this will give him a severe form of scabies. There's less of a fight against the parasite. And there's a specific name for that type of scabies. They call it hyperkeratotic scabies. And this is very bad. You'll see this especially in people with decreased immunity. So this is hyperkeratotic scabies. This can be bad, especially if you're immunocompromised. Another bad prognosis, and this is especially occurs with anyone who has constant itching. You see, whenever you itch this part of the lesion, as you itch, you can lead to the development of a secondary skin lesion known as excoriation. This basically means you can lead to a linear, basically scar-like thing being developed in the lesion as a result of constant itching. So this problem with this itching is that you can give a chance for bacteria to enter through. You can basically form a crack. So the constant itching of a skin lesion, and this leads to development of excoriation, and basically excoriation can lead to development of a bacterial infection secondary to it. You basically can create a gap you can create a gap or a crack that allows the bacteria to enter through. And that can create a secondary bacterial infection, and that's actually bad. And you can tell this can be a secondary bacterial infection eventually with development of pustules and fever and whatnot. Okay? So that's another thing that may be a bad prognosis in the treatment. Another one is post-sebatic pruritus. Now let us say for examples, just hold on. Let us say for example that a patient, has scabies. All right, we did treatment for this patient, and I'll tell you the treatment. But let's say we did treat the patient, okay? And let's say after like 1 week or 2 weeks, he still has scabies, right? If this patient still has scabies, and we confirm it through diagnosis, through clinical diagnosis, through light microscope, if this patient still has scabies even after treatment, that can mean a number of things, all right? Now remember, the treatment for scabies is not just for one affected individual. It has to be to everyone who came in contact. So if we have a child who has scabies and we give him, for example, a cream to treat it for him, then not only will this baby receive this cream or an oral treatment for it, the whole family in his house must receive it because, again, it's very contagious. So when this baby comes to you again with scabies, it can mean a couple of things. It can mean, number one, that maybe there is resistance to the treatment. Maybe the scabies, it is resistant to the treatment of a cream being applied to the skin. So in that case, we could give him an oral treatment. We could give him ivermectin, which is basically a medication that can be given orally instead of topically. Or it could be a case of maybe the family or one of the members, they did not get treated with scabies. Maybe you treated the mother and the father, but you didn't treat the brother. So the brother got a case of scabies and then he transmitted to the other families. So maybe one member of the family didn't get treated. Or number three, maybe you didn't apply the medication correctly, right? Maybe you didn't apply the medication in a correct manner according to the doctor, and that can lead to still the appearance of scabies. Or the last cause as to why there might be failure of treatment to scabies is maybe they didn't apply the medication. Maybe they just didn't apply it. And as a result, scabies is still prevalent in the family. So that's why if a patient still has scabies despite treatment, it might be resistance or it might be something involving in the family. Maybe someone didn't get treated, maybe they didn't apply the medication correctly, maybe they didn't put the medication at all. Who knows, okay? So let's say in that case, in one scenario, we already mentioned that a patient might have scabies, meaning he still has the same symptoms. Severe itching at night, and you confirm some diagnosis, right? After treatment. So let's say this patient has itching after treatment, and you confirm that this patient does not have scabies. He has itching, but it's not itching during the night. It's also throughout the day, all right? He has itching throughout the day, and he doesn't have any skin lesion that represents scabies, right? He look under a microscope of a skin lesion, you don't see any of the mites. So he doesn't have scabies, but this patient still comes to you with pruritus after treatment. So this could this be scabies still? No. This could be known as a case of post-scabitic pruritus. This basically means that as a result of a child or someone who had scabies, as a result of someone with scabies who constantly itches, I said before there can be a risk of secondary bacterial infection. And yeah, that can occur. And you have to give antibiotics in that case. But let's say also with constant itching, and this can lead to the development of dermatitis. And if there's development of dermatitis, you know that can be accompanied with itching. So that might be the case here. The patient who has scabies and he still itches, it can lead to the development of dermatitis, similar to allergic or contact dermatitis, and that can come with the patient with pruritus throughout the day. So as a result, even despite treatment for scabies and it actually resolved the scabies, the patient still comes to you with itching now throughout the day. So now what are you going to do in the case of post-scabitic pruritus? Well, what you're going to do is you're going to treat this patient the same as eczema, okay? You're going to give this patient basically corticosteroids topical to resolve the itching, okay? So this post-scabitic pruritus is not due to scabies. The scabies is treated. It's due to constant itching that can lead to development of dermatitis. So you treat it the same as eczema, so you can give this patient topical steroid. So that doesn't mean that's bad prognosis or something that's really that makes the treatment not as responsive. So that's why, now that we've got the prognosis out of the way, that's why since we talked about prognosis, now we can go to the treatment for scabies. So the treatment is, again, patient education, family education, if he has anyone in the family or anyone that lives at home with him, anyone that lives with him has to have an education about scabies. And not just that, not just the patient, everybody as well needs to have a cream applied on them as well. So if a patient has scabies, he has to take a cream known as Parasitic cream. This is a cream that's good against scabies parasite infection. So you can apply it topically in the form of a cream, and you apply it properly according to where the skin lesion, in the wrist or in the fingers or whatever. And you apply this cream not just for the affected patient, for anyone that lives close to him. Anyone that is living at the same household as him, they must get the cream as well. And they must be educated as well. For example, scabies that might be living in clothes. So if they have scabies that might live in clothes, you tell the patient, all right, take all your clothes and you basically wet it, all right? You basically clean it with boiled water, for example. You clean any clothes with boiled water. You avoid touching personal objects unnecessarily without washing your hands, for example, and not forget to apply the cream for everybody else, okay? That's the biggest treatment in the case of scabies. And let's say we have a resistance to a scabies in the case of treatment. Let's say this Parasitic cream, this does not work against scabies, not a problem. We're going to use the ivermectin, which is an oral form of permethrin, all right? An oral treatment of ivermectin, the oral form of ivermectin, or the oral form of permethrin cream. Ivermectin can be used in case of resistant cases or in case of severe type of scabies, like hyperkeratotic scabies, okay? That's pretty much it for the scabies. Now let's talk about the lice, or lice which is caused by another parasite known as pediculosis something. Now lice is the lice. You've heard of the term lice. Someone has said he has lice in his facial hair, or lice in his hair, or lice in his pubic region, all right? So you've heard of many different types of, many different variety of lices, maybe in televisions. The patient has a lice in his hair, facial, or his haircut, or in his pubic area. And the lice typically comes in the form of contact, any form of contact. And the contact variety, it could be contact with a person, contact with an animal, anything. And it can be also contact, there can also be contact via sexual transmission. Like in the case of lice in the pubic hair, that can come due to sexual transmission, all right? But regardless, the transmission is through contact, the same as scabies, all right? And in that case, they have a parasite, right? We're gonna call it pediculo. Pediculo, basically this parasite, once it comes in contact with the hair follicle rather than the skin, you see this lice right here, this is actually the person. You see this lice right here, if we do a zoom in his hair follicle, basically what the lice does is that it will come in the hair follicle and it will start to deposit its eggs, right? So you have basically this lovely lice that starts to deposit itself in the hair follicles. And what does it deposit itself? It deposits its eggs. And those are the eggs, or they call it nits. N-I-T-S are the same thing as eggs of a lice. So the lices, they like to deposit its eggs, especially at the hair shaft, very firmly. So when you look at a patient's hair very closely, you might see in his hair tiny little spots, tiny little white spots. So you can look at two hair follicles in the color black, and you see these tiny little spots, or these tiny little nits. These nits are the eggs of a lice that are deposited by the mother. And this is a characteristic feature, a pathognomonic feature of lice. Once you see this, you can clinically diagnose it as a case of lice, okay? So you can see in this patient right here, like this child, you have a child where you can expect on his hair, he has a mohawk, and you can expect in his hair that there is the presence of multiple nits or multiple lices, these tiny little white spots in his hair. That's not dandruff, that is more than likely to be nits or eggs of lices that are firmly attached to the hair shaft. Unlike dandruff, dandruff can be flaked off. But in case of nits, no, they're attached to it very tightly, okay? So that is really a clinical feature of lice. The only thing a patient might complain of is itching, maybe slight itching, right? He might complain of itching very slightly. But besides that, you'll just see the presence of nits otherwise, okay? Also, another thing also to keep in mind too, maybe this patient's hair will be smelly as well because of the lice depositing itself in the hair follicle. Because it deposits itself in the hair follicle, this hair could be smelly as well. So you can inspect closer in the hair, and you'll see that it's smelly, right? It has a very weird smell or very bad smell. and you'll see the presence of these eggs, then you can think to yourself, okay, this might be a case of lice, definitely, okay? But here's the thing too. Here's another thing too, right? Let's say this patient, for example, is immunocompromised, right? Let's say this patient has bad luck, right? He has bad luck, and let's say he has itching in this area, right? And he constantly itches, right? Let's say he's immunocompromised, or he's constantly itching, right? In this region. If he constantly itches at his hair follicle, then again, this can lead to a crack that can let bacteria enter through. And if you have a bacterial infection secondary to this itching, then this can be in bad prognosis in the case of lice. And you see, especially in terms of children, you see, typically, normally with lice, patient may only come to you with mild itching, and you'll see only the presence of nits in his hair, the eggs on his hair follicle. But with constant itching, this can lead to development of secondary bacterial infection. And the development of secondary bacterial infection will lead to the clinical presentation of a child. They may come to you with a cervical lymphadenopathy, right? So this is basically the neck, and there's an enlarged swelling or a swelling in his neck. And this is basically cervical lymphadenopathy. That is a clinical presentation of a secondary bacterial infection. Along with it, patient may come to you with fever. So if you see a case of a child who has a history of lice, let's say, or let's say you don't know he has lice, but you can see from this patient he constantly is scratching his hair, so it's itchy, and you see in his hair follicles multiple nits, and you also see at the same time this child has an enlarged cervical lymph node and he's feverish. So you tend to think of this as a case of pedunculosis, which is accompanied by a complicated secondary bacterial infection. You see, cervical lymphadenopathy fever, this doesn't necessarily come from the pedunculosis. No, this comes from the secondary bacterial infection that occurred due to pedunculosis. So these come from the bacterial infection, but the remaining ones, the itching, the nits, and the smelly hair, these come from the lice itself, okay? So that's the clinical features together. All of these together can be the possible clinical features or the clinical presentation of lice or pedunculosis. So what is the treatment for pedunculosis? The diagnosis is again clinically. You can clinically diagnose it easily. But what is the treatment for pedunculosis or lice? Well, it's basically the same as scabies. You give this patient what? Permethrin cream. You give this patient permethrin cream, you apply it in the hair follicle, and then from that point on, you'll see it will resolve itself, okay? But you make sure you also educate the patient or you educate the family as well, okay? So you give permethrin cream along with education for the family, okay, regarding lice and also regarding scabies. That's pretty much it for the parasitic infections. Thank you.